we hear you. Please start.
So I start, yes. Okay. I hope you enjoyed your coffee break, or still do, some of you. Second part, I want to talk a little bit about our experience with steroids. Luckily, there is a lot of data by now out, and it seems really that steroids is a form how we can decrease mortality in COVID-19. I want to lead you a little bit through how it all started, what recommendations we had in the beginning. I want to go into data, steroids in influenza and SARS, and then just briefly corticosteroid use in ARDS, and then importantly, only then I will switch to COVID-19. We'll finally discuss a little bit special situations and end up with a suggestion how we should proceed with steroids. Interestingly, as some of you will remember, in the beginning, many guidelines said we should not use steroids. Like the German guideline said, Steroide sollten bei ARDS in keinem Fall routinemäßig gegeben werden. Steroids should not routinely be used in ARDS patients. Or the WHO said in the beginning, we recommend against the routine use of systemic corticosteroids for the treatment of viral pneumonia. Again, we suggest against the routine use. In ARDS patients, we suggest using systemic corticosteroids over not using corticosteroids, but this was a weak suggestion. So in the beginning, the situation was quite different. We weren't sure, should we use steroids? Actually, many said, no, you should not. Why was that? This came actually from the data we had with influenza, and the next 3 slides is now about steroids and influenza, and this is a Cochrane analysis, which looked into mortality of hospitalized patients with influenza and the use of steroids or not using steroids, randomized controlled trials. And actually the final outcome of this was that when you use steroids in severe influenza, in many studies, mortality actually increased. So there was a tendency to say, no, don't use steroids in influenza. You may not be able to clear your virus anymore, and you may get more severe complications and side effects from steroid use. This was unadjusted mortality favors not using steroids. Adjusted mortality again favors not using steroids. There was actually a strong odds ratio of 3.9, which was highly significant not to use steroids. What about hospital-acquired infections? In patients on steroids, yes, there was a higher number of hospital-acquired infections than these patients who got immunocompromised with steroids, and again, an odds ratio of 2.74 against the use of steroids. However, already in this Cochrane analysis, they said, retrospectively, it was unclear whether possibly patients with more severe influenza had been selected to receive steroid treatment. And they also concluded they were not able to determine whether additional steroid treatment in people with influenza is truly harmful or not. Further clinical trials are warranted, as always. And the final judgment was, in the meantime, the use of steroids in influenza remains a clinical judgment call. But overall, from these data, we were skeptical using steroids in influenza, pneumonia, and ARDS. What do we know about the use of corticosteroids in SARS? SARS is a coronavirus. As you know, we had an outbreak in 2002, 2003. Luckily, in Germany, there were almost none. And actually, after this outbreak was over, the WHO requested to do a systematic review on treatment effects. There were 54 SARS treatment studies, 15 in vitro studies, 3 ARDS studies, so quite a low number and low numbers of patients. And there were overall 29 studies on steroids. Of those 29 studies, you see it down here. Corticosteroids were inconclusive in 25 of these 29 studies. And in 4 studies, steroids were potentially causing harm. There was no study which was pro-steroids in the SARS cohort, so it was not possible to determine whether treatments benefited patients during the SARS outbreak. This was the second reason why in the beginning steroids were deemed should not be used in patients with COVID-19. Also, in the light of these patients, as you all know, there is quite a significant number of intensivists who are in favor of routinely using steroids in ARDS. And I just want to go a little bit into data in these patients. And this meta-analysis was actually done in the light of COVID-19, but was looking not into COVID, but into early ARDS. This is 1,093 patients in randomized controlled trials with early ARDS, mind you, not COVID-19. And there was a clear, significant advantage for steroids, methylprednisolone in 322 patients, hydrocortisone in 494 patients, dexamethasone in 277 patients, all randomized controlled. There was a significant improvement in ventilator-free days for methylprednisolone, for hydrocortisone, and for dexamethasone. And there was also a reduced duration of mechanical ventilation in patients who received methylprednisolone or dexamethasone. Both were significant. This is the final picture. You see here hydrocortisone, different studies, methylprednisolone, different studies, dexamethasone, only smaller studies, or only one study which was recently published. However, overall, in all these three corticosteroids, there was favor in favor of glucocorticoids. You should use glucocorticosteroids in early ARDS. And then we had on the 16th of June, the report from the recovery trial, which was big news at that time. This was reported before any results were out, and it said low-cost dexamethasone reduces death by up to 1/3 in hospitalized patients with severe respiratory complications of COVID-19. You will remember this were big news, and actually a lot has changed since. The recovery trial is published by now in the New England Journal, and I want to go with you a little bit more into the data. It was an open label trial, so it is not blinded. It was randomized, and there was a dose of 6 milligrams of dexamethasone given for up to 10 days compared with patients who got just usual care. In the end, they had more than 2,000 patients on dexamethasone in the UK and 4,321 control patients. On average, the age was 66.1 years. At randomization of these 2,100 patients, 16% were on ventilation, 60% received oxygen supplementation, and 24% of the patients had neither ventilation nor oxygen support. The primary outcome was mortality at 28 days. And when we go into the results, looking at all patients, you see the patients with usual care in black and those in dexamethasone in red. There was a significant favor for the dexamethasone overall group, where there was a reduction of mortality to 22.9% versus 25.7% for patients who did not receive corticosteroids. When we go a little bit into more detail, those who had invasive mechanical ventilation, 1,000 patients, there was a huge difference between the two cohorts. The usual care patients on ventilation without steroids had a 41% mortality. Those who got dexamethasone, 29.3%. So a highly significant improvement in mortality. A little bit less, but also significant for those who received oxygen only, so were not ventilated. There was also a better outcome for the dexamethasone group. Interestingly, those who had no respiratory support, did not receive oxygen, were not ventilated, actually had a better outcome with usual care. So those who did not receive oxygen, there is probably no indication to give dexamethasone. At the moment, we have no data to support this use. Remember, those who had a profit were those on mechanical ventilation and those on oxygen support. 41% versus 29%, 26% mortality versus 23%. And the conclusion was the recovery trial provides evidence that treatment with dexamethasone at a dose of 6 milligrams once daily for up to 10 days reduces 28-day mortality in patients with COVID-19 who are receiving respiratory support. Now, already at that time, there were a number of randomized control trials going on in different ICUs around the world. And the big problem now was that these trials could not be finished because the ethics committee said you have to stop your trial now. Yeah, there is a clear trial now in favor of dexamethasone, and you cannot continue doing a randomized controlled trial. A number of these trials have been recently published in the JAMA online. Due to time restrictions, I will not go into detail, all quite interesting to read and to analyze. But there was also prospective meta-analysis on these data published by the WHO, which I want to discuss with you. They included 7 randomized controlled trials, either on dexamethasone, hydrocortisone, or methylprednisolone. Overall, 678 patients versus placebo patients. They included critically ill patients who were either on intubation or had high flow oxygen or had oxygen support of more than 6 liters per minute. So a number of patients from the recovery trial were actually excluded. I think they only took the ventilated patients into this meta-analysis. Primary endpoint was all-cause mortality at 28 days. The secondary endpoint was severe adverse events in these patients. To show you briefly the results here, 28-day all-cause mortality according to the corticosteroid drug. We have dexamethasone up here, hydrocortisone here, methylprednisolone down here. And you see in all 3 cohorts, there was a favor for corticosteroids. So it may be a little bit stronger with dexamethasone, maybe a little bit less with hydrocortisone, maybe again better with methylprednisolone, but I think the data are not strong enough to compare different corticosteroids. Overall, no matter which corticosteroid you used, mortality was improved with the use of steroids. When we look at patient characteristics, which patients profited more from corticosteroids? Invasive mechanical ventilation, yes, they profited. Interesting, taking vasoactive medications, those who had no vasoactive medication profited more than those who were on vasoactive medications. A little bit difficult to understand because usually we give steroids in those who are on septic shock and vasoactive medication. Age didn't matter, both younger and older patients profited. Sex didn't matter, both male and female profited. And it didn't matter whether they were symptomatic for less or more than 7 days. So overall, there is now a strong suggestion, use corticosteroids in patients with COVID. Concerning serious adverse events, I think the data were not very good, but at least there was no clear signal that there were more severe adverse events with corticosteroid use. Coming slowly to the end, these difficult patients in late ARDS who have COVID-19, we just discussed, they are sometimes very stiff. I show you 4 CT scans here of patients who were in my ward with COVID-19 on ECMO. 39, 63, 69, 51 years of age, 42 days on ECMO, 64 days on ECMO, 66 days on ECMO, 71 days on ECMO. All survived, all came off ECMO. Is there a role for corticosteroids in these patients who have very stiff lungs, whom you cannot ventilate, whom you have to oxygenate with ECMO? Well, to be honest, we are not sure. Many centers try, so do we. There is, to be honest, no randomized data and there is no long-term data, which I think is a problem because these patients may develop many complications with long-term use of steroids. However, if a trial is undertaken, which we do in these patients, we exclude secondary infections first. We would do bronchoalveolar lavage, exclude viral infections, exclude as far as possible fungal infections. Only if this is negative, we would start a trial. Generally give 3 times 100 milligram of prednisolone for several days and see is there an improvement or not. If there is no improvement, we terminate the trial. If there is a slight improvement, we would try to come down with our corticosteroids to 1 milligram per kilogram. But we are not sure whether this is the right treatment or not. However, we do. Yeah, do not forget your side effects. Do your fungal prophylaxis. They are very much prone to fungal infections if they have not only COVID, but also are on steroids. To summarize, steroids in COVID-19. What about the timing? I would say possibly at the beginning of the adaptive immune response, not too late. always keep in your mind, are there super infections, viral or fungal? And also, of course, consider the side effects of steroids like osteoporosis, hip necrosis, cataract in the long run. So I think it depends on the severity of disease, whether you give steroids or not. These have to be in patients, in hospital. They have hypoxemia needing at least oxygen substitution. Yes, we would use dexamethasone now. When they go on oxygen, we use 6 milligram dexamethasone per day. If they have ARDS and are on ventilation due to COVID-19, yes, maybe even higher doses are needed. Some people use 2 times 40 milligram of methylprednisolone or 2 times 6 milligram of dexamethasone. What about this hyperinflammation syndrome? Yes, we do use steroids, but you may need even stronger immunosuppressants like anakinra, as I mentioned before. What about these patients with very stiff lungs, seemingly with lung fibrosis, very low lung compliance on ECMO? Probably yes, we give a trial of steroids. Remember, we do not really have good long-term data on side effects, and I still think an individualized approach has to be necessary on the foundations of current knowledge. Thank you very much.
Thank you, Thomas. A very nice presentation. It's a controversial theme, and I have a lot of questions about steroids and ECMO steroids and RDS. But my first question, what do you think about the idea of Gattinoni that RDS in COVID-19 is different RDS than, for example, RDS in other viral infection like H1N1 or things like that? And second question is, do you think maybe there is really 2 subtypes of RDS in COVID, like some hypothesis from Brody from New York or some researchers from California, that some patients have hyperinflammation and some patients have hyperinflammation RDS during COVID?
To the first question, yes, I think they are different. Patients are different, especially in the beginning, which may be due to the fact that COVID-19 may infect the endothelium. So they get on one side hyperperfusion, which we have seen in the perfusion CT scan. They may have hyperperfusion in the periphery. They may develop shunts. But in parallel, there may be endothelitis, and they may also develop local thromboembolic occlusion of vessels. So the pathophysiology probably for COVID is specific. COVID is a very interesting virus which seems to affect many organs, including the pulmonary circulation. In the later run, my feeling is, apart from these strange hyperinflammatory syndromes, which some develop, the ARDS is comparable to what we know. That was our impression. Also, after 14 days, the hypercoagulability seems to decrease. And we have seen often typical pictures of ARDS, very stiff lungs, which we treat according to what we know from other diseases. Different phenotypes, yes, there are. Patients seem to respond different to the virus. It probably also depends whether you have already an immune response to the virus or not. Interestingly, we have seen patients like post-bone marrow transplantation or with liver insufficiency who seem not to react to the virus, had very high viral load, did not develop antibodies, and were not severely sick. But I think this is often not different phenotypes, but it goes from one phenotype to the other one. So you may have the hyperinflammatory syndrome later on in the course. Why it develops, I'm not sure. And what exactly goes on, I'm not sure either.
Thank you, Thomas. And some questions from the audience. So I have... Yes, Evgeny. Use microphone.
Я на русском тогда скажу. Томас, спасибо за вашу лекцию. Мой вопрос следующий. Что было бы точкой в лечении пациента с РДС и COVID когда бы вы прекратили кортикостероидную терапию?
Thomas, do you hear translation?
No, you have to translate for me.
Okay, I'll try to translate. Thomas, thank you for your lecture. And the question, what's the indication to stop corticosteroids during COVID?
Good question, I can't answer. It's actually a difficult question. Now, the studies have done 10 days. This is what we have. But for me, it's difficult. When I can talk about hydrocortisone, which we use in septic shock, we would decrease slowly when we see that the inflammation is controlled. We would halve every day and slowly come out of it when we are on low dose of vasopressors. We would not stop immediately. Whether this is true for dexamethasone as well, I'm not sure. There is also studies which slowly decreased it. Maybe in these who are on ARDS, we should do 10 days of full course and then another 5 days of half doses. But there is very little data on that.
Maybe some laboratory markers, CR, protein, ferritin, interleukins, something else.
The problem is when you go in with dexamethasone, C-reactive protein always seems to come down. Not necessarily meaning that inflammation is coming down. They may still have ongoing inflammation and C-reactive protein is low. But of course, this would be one of the things when your ferritin is controlled, when your patient is clinically not septic, we would decrease, yeah.